So welcome to today's deep dive. We're tackling something today that I think is going to really challenge a lot of assumptions you might have.
Oh, absolutely. It's a huge, honestly, pretty pervasive misconception.
Right. Because when you picture a child struggling with a mental health issue in a classroom setting, there's this deeply ingrained expectation of what that looks like.
Yeah, you picture disruption.
Exactly. You picture the kid who's acting out, throwing chairs, crying really loudly, or I guess maybe completely withdrawing and just refusing to participate at all.
Right, because we expect the struggle to be loud.
We really do. We're totally conditioned to look for those visible, audible signs of distress. But today, our mission is to sort of dismantle that. We are looking at the quiet worry inside a child's head.
Which is so important.
Yeah, and we're going to talk about why it's so chronically missed and how new teletherapy models, specifically looking at an initiative in Georgia called MentalSpace School, are trying to solve this massive access crisis for families.
It's just incredibly common to only react to the squeaky wheel,
Oh, for sure.
Like if you're a parent or an aunt or uncle or a teacher,
Yeah.
your attention actually just gets drawn to the behavior that disrupts the environment.
Right. The stuff you literally can't ignore.
Exactly. But childhood generalized anxiety disorder, or GAD, completely defies those standard expectations. The reason it goes unidentified so frequently is that these kids, well, they present as the good ones.
Right. They're the easy kids.
Yeah, they're quiet, they're compliant, they are hyper-prepared.
I was reading through the sources, and it's basically like a suspension bridge, right?
Oh, that's a good way to put it.
Yeah, like it looks perfectly stable from the outside. It's holding all this weight. Traffic is flowing smoothly, meaning, the grades are good. The behavior in class is totally fine.
Right.
But structurally, these microfractures are multiplying underneath until the stress is just too much.
Yeah.
And the tragic part is the child is heavily praised for being so focused. But internally, they're suffering from this paralyzing perfectionism.
They really are. And that structural tension, it has to go somewhere.
Yeah.
And you see this leak out in what we call redo loops.
Okay, wait, explain the redo loops. That stood out to me in the excerpt.
So a child isn't erasing a hole through their spelling worksheet at 9 o'clock at night because they're just, a dedicated student who really loves spelling.
Right.
They're doing it because their anxiety literally won't allow them to accept a perceived flaw.
Wow.
The brain is telling them that any imperfection is a complete catastrophic failure.
That sounds exhausting.
It's incredibly exhausting. And in a classroom, like during a presentation, this often looks like a severe reluctance to raise their hands or speak up.
Oh, and let me guess, that just gets labeled as shyness.
Exactly. They develop this whole pattern of social avoidance that neatly and completely incorrectly gets mislabeled as simple shyness.
Which means they don't get the help they need. And the physical toll of holding up that bridge, of doing that all day, is immense.
Yeah.
The sources mention that clinical criteria require these signs to last for 6 months or longer. So we're talking about persistent, hard-to-control worry across multiple areas.
Right. School, family, friendships, sports.
Yeah, and it comes with severe fatigue, muscle tension, sleep disturbances. But I wanted to push back on one thing here, or at least ask a clarifying question.
Sure, go for it.
Kids get morning stomachaches before tests all the time. Like, I did that.
We all did.
Right. So how does a parent or teacher actually know the difference between a clinical, physical symptom of GAD and a kid just faking a tummy ache to get out of a math quiz?
That is the big question.
Yeah.
And the difference lies entirely in the pattern and the persistence of the worry.
Okay.
So a kid faking a stomachache to get out of math, that's an isolated incident tied to one specific stressor.
Right, the math quiz.
Exactly. Once the quiz is over, or they successfully avoid it, the distress vanishes. They go back to playing video games or acting like themselves.
But with GAD, it doesn't go away?
No, it doesn't vanish at all. It just, it migrates to the next target.
Oh, wow.
First it's school, then it's a friendship drama, then it's an upcoming athletic performance. The worry is generalized, meaning it's constantly hovering, just looking for a place to land.
That makes so much sense.
And because these children are so adept at compensating by being good, the actual diagnostic criteria are different for them than for adults.
Yeah, I want to unpack that because that's a critical point for anyone listening who has kids in their life. For an adult to be diagnosed with GAD, the clinical criteria require 3 somatic or physical symptoms.
Right.
But for a child, it only takes 1 somatic symptom. Just one.
Yep. And that lower threshold exists because children simply do not have the cognitive development or really the vocabulary to articulate a feeling of impending dread.
Right, a 7-year-old isn't going to sit down and say, Mother, I'm experiencing pervasive anxiety regarding my future performance
Right,
metrics.
exactly. Their bodies literally have to speak for them.
Wow.
So that single somatic symptom, whether it's the persistent morning stomachache or unexplained neck pain from muscle tension or just not being able to stay asleep, that's the body's warning light blinking on the dashboard.
Letting you know the engine is running way too hot.
Exactly. Even if the exterior of the car looks perfectly polished and shiny.
So, okay, now that we understand how incredibly sneaky these symptoms are and how well they hide behind straight A's and quiet behavior, we naturally have to ask about the scale. Like, if it's hiding in plain sight, just how many kids are actually carrying this invisible burden?
It's a lot. Generalized anxiety disorder is one of the most common pediatric mental health conditions there is.
The numbers in the sources were kind of staggering. The 12-month prevalence is near 2.2%, and the lifetime prevalence is near 9% in U.S. youth.
Right. And to put that into localized perspective, specifically looking at the Georgia data, up to 1 in 12 Georgia students will experience GAD by the time they reach age 18.
1 in 12. So if you picture a standard classroom of, what, 24 kids?
That's 2 or 3 students in every single room.
Every room.
Wow.
Yeah. So to catch these cases early, the medical community relies really heavily on universal screening tools, usually done at well-child visits at the pediatrician's office.
Right. Those tools being the SCARED assessment and the JD-7 adolescent.
Yes.
And what's cool is they aren't just generic checklists. Like the SCARED assessment, which stands for Screen for Child Anxiety-Related Disorders, actually asks specific questions to bypass that lack of vocabulary we talked about.
Exactly. It asks things like, do you worry about what is going to happen in the future?
Or do you feel like you're passing out when you get worried?
Right. And the GAD-7 asks about feeling nervous or on edge over the last 2 weeks.
But here's a question. If these screening tools exist and educators know what to look for now, like the reassurance seeking and the homework redo loops, why can't a teacher just flag a student for JDA and get them help immediately?
Oh, we have to draw a very hard line here between screening and diagnosing.
Okay, break that down for us. Diagnosis must always come from a licensed clinician, never just from an educator's or a parent's observation.
Really? Even if it seems obvious.
Especially then, applying a clinical label like GAD without a highly structured clinical interview can actually be really detrimental to the child.
Oh, because you might be treating a symptom but totally missing the root cause, right?
Exactly. Think about it. If a teacher sees a kid redoing their homework over and over and begging for reassurance, they might assume, oh, it's pure anxiety.
Right.
But what if that child actually has an undiagnosed learning disorder, like dyslexia or dyscalculia?
Oh, wow. So the anxiety is just a secondary reaction to the fact that they literally can't process the reading material.
Exactly. Or what if it's ADHD? And they're redoing the work because their brain keeps losing focus, they make careless errors, and it totally frustrates them.
That differential diagnosis is everything then.
It's everything. A licensed clinician uses a structured interview to differentiate GAD from a massive host of overlapping conditions. They have to rule out OCD, social anxiety, separation anxiety, depression, ADHD, learning disorders, all of it.
Because if you skip the clinical diagnosis and just throw anxiety treatments at a kid who actually has a learning disorder, you're treating the wrong thing.
You're treating the wrong thing, and the child continues to struggle.
Yeah.
And honestly, often their secondary anxiety gets even worse because they feel like the treatment is failing them.
That makes total sense. So, okay, let's say a licensed clinician has done that careful untangling. They've ruled everything out and confirmed a diagnosis of GAD. The immediate next question for any family is, what actually works?
Right.
How do we help these high-achieving, silently suffering kids? The evidence-based gold standard is cognitive behavioral therapy, or CBT, right?
Yes, CBT is the gold standard. And for younger children, there's a highly specific, very well-studied protocol called Coping Cat.
Coping Cat. I love that name.
It's great, right? And it's fascinating because of how it breaks down this giant monolithic concept of anxiety into really manageable pieces for a kid.
How does it work?
It typically runs for about 16 sessions. The first half is purely educational.
Okay.
It teaches the child to recognize the physical signs. So identifying what those butterflies in their stomach actually mean.
Right, tying the physical to the mental.
Exactly. It helps them identify the anxious thoughts and then develop a concrete coping plan to face their fears instead of avoiding them.
And the second half.
The second half is gradual exposure. They practice using those coping skills in real low-stakes situations. And then for older kids and adolescents, they frequently use group CBT.
Which I imagine helps them realize they aren't the only ones dealing with these overwhelming thoughts.
Huge factor. Just
Hmm.
knowing you aren't alone is half the battle.
Now, along with the exposure-based therapy and family-based CBT, there's also a pharmacological component mentioned in the
Right,
sources.
the medication side.
Yeah, when a licensed psychiatric provider determines it's medically indicated, they use pharmacotherapy. So we're talking about SSRIs here, selective serotonin reuptake inhibitors.
Yes.
Things like sertraline, fluoxetine, escitalopram. But understanding how the medication interacts with the therapy seems crucial.
It really is.
If I'm understanding this right from the reading, if CBT protocols like Coping Cat are like installing a new internal software operating system for the child's brain to process worry,
I like where this is going.
then for moderate to severe cases, adding the SSRI is like turning down the volume on the hardware's overheating fan so the new software actually has the bandwidth to run and install properly.
That is a brilliant analogy, yes.
Yeah.
It's the exact mechanism of action we're aiming for.
It makes sense. You can't learn when you're panicked.
You absolutely cannot expect a child to learn complex cognitive coping skills when their nervous system is in an active state of severe panic. It's impossible.
Right.
And we actually have empirical proof that this combined approach works best, primarily through the landmark CAMS trial.
CAMAS, which stands for the Child-Adolescent Anxiety Multimodal Study.
Right, and in clinical research, a trial is considered a landmark when its results are so definitive that it fundamentally changes the standard of care across the medical community.
And the CAMS trial proved that for moderate to severe pediatric anxiety, combined treatment, so CBT paired with an SSRI, consistently outperforms using either method alone.
Exactly. It gives the medical community the definitive why behind the protocol.
It proves that addressing both the physiological chemistry of the brain and the cognitive processing skills gets the best outcomes.
Absolute.
And by ensuring therapies include family-based and group settings, it makes sure the child isn't fighting the battle in a vacuum. Mental health recovery really is a system-wide effort. It involves the child, their peers, the family unit.
It takes a village. But, and this is a big, but having the diagnostic tools and the proven treatments, like Coping Cat and the CAMS protocol, it brings us to a massive systemic roadblock.
The wait lists, the wheat lists. None of that amazing science matters if a child's quiet worry has to sit on a 6-month clinic referral waitlist.
Right.
Getting an appointment with a licensed pediatric psychiatrist or a specialized therapist right now is incredibly difficult. It's the major bottleneck of modern K-12 mental health care. The science of how to fix the problem is there. The access to the solution is what's broken.
Which brings us to the really exciting part of today's deep dive. The operational solution presented in our sources, bringing the treatment directly to where the kids already spend the majority of their days, inside the school building.
Yes.
This is where that initiative called MentalSpace School comes into the picture. They're providing K-12 mental health support specifically for Georgia schools, right?
Right.
And they're directly attacking that access bottleneck. They don't just offer an offsite referral that forces a parent to figure out the healthcare system alone. They provide dedicated, culturally competent teletherapy teams per school.
And the mechanism of school-based teletherapy is what makes this so effective. I mean, think about the traditional referral system. It's a nightmare.
It is. A child goes to the guidance counselor, gets a piece of paper, and takes it home. The parent has to find an in-network clinic, call them sit on a wait list for months.
Take time off work.
Exactly. Take time off work, pull the child out of school early, drive across town to a sterile clinic, and then drive them back. Every single step in that chain is a point of friction where a family might just drop out of the process.
But school-based teletherapy removes all those physical and logistical transitions.
Completely. The child just walks down the hall to a quiet, secure room, logs onto a telehealth session with their dedicated therapist, and then goes right back to math class.
That's incredible. And they offer same-day access, crisis intervention, suicide and violence prevention, staff wellness, family counseling.
All of it.
And they've systematically dismantled the financial barriers, which is huge. For Medicaid patients, the out-of-pocket cost is $0.
$0. That's life-changing for so many families.
And they're in-network with a massive list of insurers. BCBS, Cigna, Aetna, UHC, Humana, Peach State, CareSource, AmeriGroup. It makes the process virtually frictionless.
Plus, they're fully HIPAA and FERPA compliant, meaning they protect both medical and educational privacy at the same time.
Which is super important for districts right now because of the legislative pressure.
Oh, absolutely. In Georgia, there's a mandate known as HB 268 compliance, which has a fast-approaching deadline of July 2026.
That's right around the corner.
It really is. And this legislation pushes districts to implement robust, wraparound mental health frameworks for their students. Districts are literally on a clock to figure out how to provide these services at scale. So partnering with an embedded teletherapy provider serves as a sort of plug-and-play solution to meet those mandates.
So going back to the traditional models, we always hear about the red tape in schools. How massive of a shift is it to go from that slow counselor referral system to having a dedicated same-day teletherapy team right in the building?
It is a total paradigm shift. Yeah. And if we connect this back to what we talked about at the very beginning, the disguise of the good kid, the necessity of this model makes perfect sense.
Because they're the ones who get missed.
Exactly. These anxious kids are the quiet, compliant ones. They are exactly the type of students who fall through the cracks of a traditional triage system. Because they aren't throwing chairs, they aren't viewed as an urgent priority.
Right. But by integrating $0 Medicaid teletherapy directly into the school ecosystem, programs like MentalSpace School bypass the logistical hurdles that keep that hidden anxiety hidden.
Yes. If a teacher notices that redo loop on a homework assignment, or a school nurse notices that single somatic symptom, like that stomachache every Tuesday morning,
There isn't a 6-month wait anymore.
no wait at all. There is same-day access to a licensed clinician who can immediately do that structured interview, rule out the learning disorders, and start an evidence-based protocol like Coping Cat.
And the outcomes from removing that delay are phenomenal. Programs utilizing this model are seeing 89% improved attendance, 92% reduced anxiety, and 85% family satisfaction.
Those numbers speak volumes.
Truly. And for anyone listening who's involved in a Georgia school district looking to meet those fast-approaching July 2026 mandates, they operate through mentalspaceschool.com, or they can be reached directly at mentalspaceschool@chuhatetherapy.com.
I mean, a 92% reduction in anxiety that demonstrates exactly what is possible when we stop waiting for the struggle to become loud and disruptive before we intervene.
It really does. Well, we have covered a huge amount of ground today.
We really have.
We started by recognizing the subtle, really misunderstood signs of the good kid hiding their anxiety beneath that veneer of perfectionism.
The swan.
Right, the swans. We looked at the prevalence, the vital difference between a general screening tool and an actual clinical diagnosis, and how treatments like CBT and SSRIs work together.
Let's quiet the storm.
Exactly. And finally, how systemic school-based teletherapy solutions are bridging that massive access gap in K-12 education. For you, the listener, recognizing these quiet signs isn't just about labeling a behavior. It's about fundamentally changing how you support the young people in your own life.
Definitely. And as we wrap up this deep dive, there's one final kind of lingering question that I think we all need to mull over.
Oh, lay it on us.
We've seen that the primary symptoms of childhood generalized anxiety, the hyper-preparation, the intense compliance, the paralyzing perfectionism, they are the very traits that our society traditionally rewards with A grades and gold stars.
Oh, wow. Yeah.
Right? It leaves you wondering, if our current educational system is built to heavily reward the exact coping mechanisms of generalized anxiety, how many of our traditional measures of student success are actually just measuring effectively masked distress?